So we're going to be discussing voltage-dependent membrane potentials. Right, so depolarization and what happens when you get depolarization and what kind of channels are going to be involved. We're also going to discuss certain types of compounds and how they have effects on different types of channels. So first we're going to review ion channels. So this is some stuff that might be familiar that you covered in A&P previously. Then we're going to discuss some research type methods. So in this section, we're going to discuss the voltage clamp method. Next time, we're going to discuss the patch clamp method, which is a little bit different, but these are ways that you can measure ions and how voltage affects the movement of ions in and out of different channels. We're going to discuss in a little bit more detail the roles of sodium and potassium, and then drugs that affect either sodium and potassium channels, including, for example, tetrodotoxin. That's why I have this cute little pufferfish over here. The pufferfish is one of the sources of tetrodotoxin. You can find it in other animals as well, but it's mostly going to be from the pufferfish. Tetraethylammonium is another one that's going to affect potassium channels, which we'll discuss later. We're going to talk about how you can calculate, membrane conductance, and we're going to discuss passive versus active flow of ions and what that means. Then we're going to get into myelination and myelin disorders. So we're going to discuss, for example, conditions like Guillain-Barré syndrome, as well as multiple sclerosis. So we'll discuss those in more detail towards the end. So here's a review of how different types of ion channels operate. And again, diffusion is going to be one of the major aspects of how these ion channels operate. Diffusion going from a high concentration to a lower concentration. And the way that we're able to establish those concentration gradients is by the use of active transport, using, for example, sodium-potassium ATPase. So you create that ion concentration gradient so that, for example, sodium can be in higher concentrations outside of the cell, potassium within the cell. There's also other types of diffusion that are channel-mediated as well as carrier-mediated. Not as important for the sake of this class. But in terms of diffusion, anything that is lipid soluble basically goes right through the phospholipid bilayer. However, when we're dealing with ions are not going to be lipid soluble. Right? They're going to be charged particles, and so they're going to need some form of protein channel in order to move across the membrane. Dissolved gases, those just easily diffuse across the lipid bilayers. I mean, if you're, one great example is through respiration, right? Whenever you have oxygenation, oxygen getting brought onto the hemoglobin, that's just through simple gas diffusion. You're letting off oxygen at tissues that need it. Again, simple diffusion. When the deoxyhemoglobin gets back to the lungs, then you have the unloading of carbon dioxide. And again, that's through just simple diffusion, but not totally relevant for the sake of this class. Again, channel-mediated diffusion, things like ions require a channel. They're not just going to cross over a lipid bilayer. They need to have some form of help. It's either through active transport, through, like I said, sodium-potassium ATPase, or through an actual channel that can be operating in different ways. There's voltage-gated ion channels, which we're going to be talking about quite a bit. And there's other types of channels that we're going to be discussing later on that are going to be dependent on ligands. So you have to have a ligand binding to the protein receptor, and then that can therefore open up a channel. So that's what we're going to be talking about in part 3. So we're going to be discussing different types of ligand channels in more detail later on. And that will be a good segue into neurotransmitters and the receptors, which we're going to be discussing next week. Uniport, this is where you have a protein channel that's basically moving one ion in one direction. So uniport, example would be like a calcium pump. Symport is where you have two different molecules moving in the same direction, but they need to both be present in order for that to take place. So a good example is your sodium glucose transporter. And then you also have antiports as well, which go in the opposite direction. So the sodium-potassium pump would be an example of an antiport, where you have 3 sodiums being exchanged for 2 potassiums. Those would be antiports. Leak channels, those are going to be open at all times. They are ungated. You have sodium leak channels, you have potassium leak channels, and then you have your gated channels. And we're going to be discussing today voltage-gated channels, and then next time we're going to be discussing more chemical-gated channels. And so chemical-gated channels are going to be more associated with neurotransmitters, for example. So you have to have binding of a neurotransmitter to be able to actually open up those channels. Now, we're going to talk a lot about sodium and potassium today. Sodium potassium ATPase is one of the most important membrane proteins out there, right? Especially in neurons. A majority of ATP that's produced within a neuron is going to be geared towards letting this run properly, right? So it's like 70% or so of all ATP in a neuron is geared towards the sodium potassium ATPase. Primary active transport. So this is where you're going against a concentration gradient and you are using ATP. And so the sodium potassium ATPase, that is an example of primary active transport. Again, 3 sodiums for every 2 potassium. That's how the ratio works. There's also another type of transport that's, we're not going to go into detail in this class, but secondary active transport is where you have the primary protein, like sodium potassium ATPase. You have to have that to create the concentration gradient. And then that concentration gradient that you establish is going to now allow the second symport to work properly in this example. So you have to have that establish that sodium concentration so that glucose can also get brought into the cell as well. So you have to have one primary active transport for the secondary active transport to actually work properly. And then resting membrane potential. That's going to be really important for neurology and neurons to be able to fire properly. So sodium potassium ATPase, again, that's going to be the major thing that establishes your resting membrane potential. And as I mentioned, the majority of all ATP that's produced in a neuron is going to be geared towards making this thing work. All right, now let's discuss how ions are going to move across a membrane. So membrane potentials and sodium permeability are going to affect one another, right? So whenever you have depolarization, for example, that is going to subsequently allow for those voltage-gated channels to open up. And that's when you are able to actually get, for example, sodium to move into the cell, or potassium channels to open up as well, so you can get efflux of potassium outside of the cell. Now, the way that this is studied in neuroscience, one method is going to be the voltage clamp technique. Now, what do you mean by clamp? That means that you are able to set the voltage to a certain level. So that's what they mean by clamp. So you basically clamp the voltage in place, and you can manipulate the voltage. You can either bring the voltage up or bring it down, and then keep it at its location, and then see how the voltage affects different types of voltage-gated channels. And so if you, for example, set the voltage up and you depolarize the cell, that's going to help open up all the sodium channels. It's also going to help open up the potassium channels, which allows potassium to leak out of the cell. And so that's what the voltage clamp method basically entails. And the way that this is done is using your giant squid neuron. And so you're able to actually put in probes into the axon of the giant squid neuron, and then you can adjust the voltage on the voltage clamp, and then you can measure and see where the ions are moving, if they're moving in or out of the cell, depending on what voltage you're setting it to. So let's watch a video on the voltage clamp method. So provide a good description of how this whole thing works.
The action potential arises from the coordinated activation of 2 conductances. A sodium conductance that activates rapidly and drives the rising phase of the action potential, and a potassium conductance that activates more slowly and contributes to the falling phase of the action potential and the undershoot. How can we learn more about the behavior of these conductances? One difficulty in studying the behavior of these conductances is that they're changing over time, rising and falling as the action potential proceeds. They also change with voltage. The increased activation of the sodium conductance with depolarization causes the regenerative rise of the action potential at voltages more positive than threshold. Analyses could be made much easier if one of these elements, time or voltage, could be controlled. The voltage clamp technique does just that. It controls or clamps the voltage across the membrane to whatever value an investigator chooses, so that the changes in sodium and potassium conductance that occur with time can be studied. Let's examine how voltage clamp works. First, the neuron to be studied, in this case a squid giant axon, is placed in a dish containing saline solution. The membrane voltage, Vm, is measured by an amplifier using an internal recording electrode inserted into the axon and an external reference or bath electrode. The command voltage, Vc, is the desired membrane voltage and is set by the investigator. The difference between Vm and Vc is determined by a comparator. If Vm is not equal to Vc, this comparator generates a difference signal. This difference signal is used by the voltage clamp amplifier to generate a current that's injected into the axon via the current passing electrode in order to make Vm equal to Vc. This feedback circuit keeps the membrane voltage as close to the command voltage as possible and operates virtually instantaneously. Finally, the amount of current required to keep Vm equal to Vc, the injected current, can be measured and recorded. This means that as voltage-gated ion channels open and close over time in response to changes in Vm imposed by the voltage clamp, the current generated by these channels can be recorded and analyzed. Let's try some simple voltage clamp experiments. First, what happens if the membrane voltage and the command voltage are identical? The arrow indicates the start of the experiment, that is, when Vc is set at -65 millivolts. Since Vm and Vc are already identical and membrane currents are at their resting steady state, there is no change in voltage. Therefore, no current is injected into the axon to oppose any changes in membrane currents. Now, what happens when we impose a new voltage on the membrane by setting Vc to 0 millivolts? When the membrane potential is stepped to 0 millivolts, a very brief capacitive current is seen, followed by a characteristic pattern of inward and outward currents. The capacitive current occurs because the step from one potential to another alters the charge separation, and thus the electrical potential difference across the membrane. Once the new potential is reached, there's no more capacitive current.
All right, quick question for you guys. What ion do you think is going to be involved in the delayed outward current? From what you already kind of know of how action potentials are propagated. No. Yeah, so that's going to be the delayed outward current is going to be set by potassium. And then which one is going to be involved in the transient inward current? Sodium. Okay. Good. So this is kind of how this works. You depolarize the neuron. You can see how the voltage changes over time. And then you see from this which ions are going to be involved in that whole process. So let's continue playing the video.
Initially, Vc is at the holding voltage, -65 millivolts, which is identical to the resting potential. When Vc is adjusted to 0 millivolts, the voltage clamp amplifier injects current to push the membrane potential to 0 millivolts. Now, different types of ion channels in the axon membrane open and close, such that one sees an initial surge of inward current, followed by a more slowly developing outward current, the late or delayed outward current. The transient inward and delayed outward phases of the current trace recorded after the command voltage was set to 0 millivolts correspond to the sodium and potassium conductances measured during an action potential. Let's explore why this is so. In fact, the inward and outward currents are separate. One of them, the early current, is carried by sodium ions and is thus called sodium current, INA. Sodium channels are said to be voltage-gated, because they activate rapidly in response to depolarization. Depolarization not only causes the sodium conductance to activate, but also causes it to decrease over time or inactivate. The other current is carried by potassium ions and is called the potassium current. Voltage-gated potassium channels activate more slowly than sodium channels and do not show inactivation in axons. How do we know which ions carry these inward and outward currents? Specific blocking agents can be used in voltage clamp studies to dissect out the currents that underlie the action potential. Tetrodotoxin, TTX, a toxin found in pufferfish and in the skin of certain frogs and salamanders, specifically blocks sodium channels. In the presence of tetrodotoxin, only potassium channels open during the voltage clamp depolarization. These potassium channels can thus be studied in isolation. Tetraethylammonium, TEA, a large organic cation, specifically blocks potassium channels and therefore allows us to isolate the sodium current. This permits examination of the detailed properties of sodium channel activation and inactivation. Since the sodium current is an inward current dependent on extracellular sodium concentration, it can be eliminated by removing all external sodium. Under this condition, the recorded current is similar to the current seen in the presence of TTX, which blocks sodium channels, with one major difference. There is an initial outward surge. What is this current? Remember that even though there is no external sodium, there is still sodium present inside the axon. This sodium can flow outward down its concentration gradient through the open sodium channels.
And so if you don't have any external sodium, then you're not able to basically off-balance that electrochemical gradient. Right? So if you remove the sodium from outside, that's why the sodium from inside the axon shifts outside of the axon. So that's the voltage clamp method in a nutshell. So we did a really great job of explaining how the voltage clamp method works. And then we're going to discuss those different compounds in a little bit as well, the tetrodotoxin and TEA as well. So here's the schematic from your textbook that basically describes how the voltage clamp method works. Essentially the same thing that the narrator in the video was describing. So you have several different electrodes in place so that you can first establish what type of charge you want to set the electrodes to. That's the whole clamping of the voltage clamp. And then you can basically measure the changes in ion movement over a period of time. So first you have the capacitive current, which we're going to talk about in a second. And that's going to help to redistribute charges over the membranes. And then you have the hyperpolarization current. And that's where you have brief, instantaneous depolarization. So you're going to depolarize the current, and then when you do so, that's when you get that transient inward current. That's from the sodium channels opening up. And it's transient, and it's going to be rapid, and it's going to be a movement of ions within the axon. So from these studies, this is how early researchers in neuroscience were able to conclude that membrane permeability is going to be voltage dependent, meaning that you have voltage gated channels. So that's going to be the stimulus to allow those channels to open up. And you find those throughout the axon, and you find those especially in high concentrations within the nodes of Ranvier. The nodes of Ranvier is where you find voltage gated sodium channels. You find that at every single one of the nodes. And then not every node, but you do find them at different nodes of Ranvier, those voltage gated potassium channels as well. But the voltage-gated sodium channel, super important for allowing an axon to work properly, to propagate an axon signal. So here's a couple examples from your textbook that shows the differences between hyperpolarization and depolarization. So whenever you hyperpolarize the axon, you're going to get a little tiny blip, right? That's that capacitive current, but then it goes back to normal again. So in other words, nothing really is taking place. You just get that tiny little blip as a consequence of hyperpolarization. Then the next thing that you can do is do a depolarization. And once you depolarize, you also see a capacitive current, which just means that you're changing the voltage, and you can see that reflected in the measurement. And then all of a sudden, when the channels open up, that's when you start seeing the changes over time of the charge. So the first thing that you see is that, again, transient inward current happens briefly and rapidly versus the delayed outward current, which is going to be set by the potassium channels, the voltage-gated potassium channels. And so you can actually measure which ions are going to be involved in that, right? You can either manipulate the quantity of ions within the Petri dish, within the solution that you're studying, right, with the axon, or you can use different drugs to knock out those channels. So here's how increasing the voltage on the voltage clamp can affect the movement and current of ions. So if you were to do a smaller depolarization, right, set the clamp to about negative 26 millivolts, then you're going to get a little bit of a transient inward current. You're also going to get a little bit of the delayed outward current as well. So as you go higher and higher and higher in millivolts, you're going to see this graph change a little bit. So over here, if you set it to 0 and you depolarize to 0, you're going to get a little bit larger magnitude in the effect. So first you get an increase in that transient inward current, or the early inward current, and then you see the delayed outward current also being affected by that as well. And as you move the voltage clamp millivolts higher and higher and higher, you're going to see that the transformation of this graph. At positive 52, that's where you see the early inward current decreasing in magnitude. So you're not seeing that first bump over here. So this little tiny bump that you see, that's going to be the early inward current. Over time, as you get to a certain voltage, in this case, positive 52 millivolts, that early current basically disappears. And then once you get beyond that to, like, for example, 65 millivolts, all of a sudden you start seeing reversal of that current. And if you remember from that video that he was talking about, that could be due to sodium all of a sudden moving in the opposite direction. So current reverses its polarity at potentials more positive than 55 millivolts. And then that current basically flips over. That early inward current basically reverses itself. Late outward current, that's going to be this line over here. You're going to see that increasing with depolarization, and the early inward current is going to increase in magnitude, but then it goes away over time, so it kind of like dissipates, and then reverses to an outward current as you increase the millivolts of the probe. So that's going to be equivalent to basically sodium equilibrium potential. That's what the positive 55 is going to be. So if you go beyond that, that's going to basically flip the direction of sodium. So from these voltage clamp studies, that's basically where we found that electrochemical equilibrium potential for sodium is going to be about 55 millivolts. And at around 52 or so, if you set the voltage clamp to 52, you're not going to see movement of sodium. So it's going to basically stay static on both sides of the membrane. Now, if you remove external sodium, as you recall from that video, if you remove the sodium, then that's also going to affect the ability for the neuron to propagate the voltage, right? So you're basically going to get reversal. Sodium is effectively going to be leaving the inside of the axon and moving out into the solution. So it basically reverses the direction of movement. And so here are some other schematics from your textbook that go into more detail about how setting the voltage clamp to different levels will affect the movement of sodium. So in This first diagram over here, you're seeing how you have normal external concentrations of sodium, right? And so that's going to result in a normal-looking early inward movement. So the transient inward current. And if you were to remove sodium, again, you're going to see that that's going to affect that early transient current, right? So it's going to basically switch around, meaning that sodium from within the axon is going to move in an outward direction. Now, if you had the higher concentration of sodium outside in the solution, then you would have a nice concentration gradient, right? It would be able to move downward, down the concentration gradient into the axon. If you don't have that electrochemical gradient with sodium outside of the cell, then it's going to move in the opposite direction, basically. Now, with potassium in particular, this is going to be involved in that late current, so the delayed outward current. And so first you have your depolarization, which involves sodium coming into the cell. Again, it's going to be a transient current, so it's going to be pretty quick. And then you have efflux of potassium. So potassium eventually leaves the cell. Now, these are the compounds that you can use to basically block those different channels. Tetrodotoxin, which I'm going to talk about a little bit later, from the pufferfish. We can even compare tetrodotoxin to some other drugs that we talked about last lecture. You guys remember some of those drugs that we discussed that block sodium channels? There was like a handful. You guys remember those? What's a really good example of one that you use when you go to the dentist, or the dentist uses to do a local anesthetic? Lidocaine. Yeah, lidocaine. Lidocaine would be a great example of a sodium channel blocker. So the cane drugs, so like cocaine, lidocaine, benzocaine, those types of drugs are going to be sodium channel blockers. Tetraethylammonium is going to be specifically targeting potassium channels. So a little bit different mechanism of action. Oh, I thought we were going to be talking about this later on. I forgot I put it early in the lecture here. So tetrodotoxin is extremely dangerous. If you come into contact with a pufferfish, it could potentially kill you. So it is deadly in certain doses. But what's deadly to us for dolphins is actually quite recreational. And if you think about how tetrodotoxin is kind of similar to the mechanism of action of lidocaine, which is also similar to the mechanism of action of cocaine, dolphins might be using pufferfish as humans use coke. So kind of similar type of recreational effect. So dolphins are somewhat of party animals, sometimes even in ways that might be a little bit inappropriate. Dolphins can be a little weird around, especially women, like human women. I don't know if you guys ever heard of stories about like dolphins getting a little bit too excited when they're around females. Yeah, it is disgusting. So that's a topic for a different time. Let's watch a little video on dolphins getting high on pufferfish.
This isn't spy puffer. It's a real pufferfish. The poor creature gets the same rough treatment. Perfect for a game of catch. But the dolphins are dicing with death. Pufferfish are one of the most poisonous fish in the ocean. They exude a powerful nerve poison called tetrodotoxin. It only takes a small amount to kill a human. Even so, the dolphins often look for pufferfish and love to chew on them. Taken in small doses, the secretions seem to have a narcotic effect. The dolphins are careful not to swallow them. Instead, they hold them gently in their mouths. Despite the risks, passing the puffer has become a popular dolphin pastime.
Puff, puff, pass.
Luckily, the little fishes usually survive the strange experience.
Why is it so funny?
Because it's hilarious. Super hilarious. Imagine from the perspective of the pufferfish. They're like, what the heck is going on here? They're not trying to eat me. They're just trying to get high. So yeah, dolphins. Yeah, kind of a spirit animal there. So anyway, so with those types of compounds, tetrodotoxin, again, they block sodium channels. So here's your control, right? So under control condition, you see the early inward movement of the ions, aka sodium, and then the late outward movement of potassium over time. And so if you were to block those sodium channels, you're not going to see any inward movement, right? You're only going to see that late outward movement, which is established by potassium channels. Now, if you use tetraethylammonium, again, that blocks specifically the potassium channels. And now you see that early inward movement demonstrated over here, and basically you don't see any of that late outward movement of potassium channels. And so you can basically manipulate those different sodium-gated channels by different types of compounds. And if you were to administer other types of compounds here, I mean, if you added lidocaine to this broth, or if you added any of those other sodium channel blockers, you would see similar types of effects. So super cool stuff. So as I mentioned before, I'm not going to make you guys do any calculations for this exam. I'm not turning this into a math class. So for example, like when we discuss the Nernst equation and we discuss the Goldman equation, I just want you to like understand what those equations measure, right? What, to recap, what does the Nernst equation measure? You guys recall?
Yeah, isn't it just one ion?
Exactly, right, exactly. So it's going to be the things that impact the direction of movement of one single ion, right? So ion moving either in or outside of the cell, versus the Goldman equation. It's more applicable to real life scenarios where you have multiple different ions and you're looking at the things that affect the ability for ions to move in terms of like concentration gradients as well as overall membrane permeability. So that's what you're looking for with the Goldman equation. Here's another equation that's going to help understand what affects the currents of an ion. So membrane conductance, so you look at the current of an ion, and then you see the conductance and how that plays into the current as well as the driving force, right? So you can multiply conductance by the driving force of a given ion, and then that's how you measure current. Like I said before, I'm not going to make you guys do any calculations for our next exam. That's not my intention for this class. So if you were to look at the conductance of sodium as well as potassium, those values could be established using the voltage clamp technique as well. And so VM, that's going to be the voltage clamp setup, right? And you're going to be able to calculate the movement of ions in terms of sodium and potassium. And then you can see, for example, the electrical gradients that are required for those ions to move. In other words, the electrical gradient and depolarization that's required to open up those voltage-gated channels. And then depolarization, that's where you're able to see the actual current of those different ions. So current for sodium, the current for potassium, and then you can also see the conductance and how conductance is implicated in the actual current. So sodium and potassium conductance is going to change over time, right? So you have the fast sodium channels and you have the slower potassium channels. So these are different ways that you can calculate, basically the same kind of idea. So here's a depiction or a diagram from your textbook. So on the top, you see the different, membrane currents, right? So set again by the voltage clamp. So you could set it to, for example, -39, -27, -2, etc. And you can see how that affects the conductance of sodium and how that affects the conductance of potassium. And again, sodium is going to be the first one to rise. So you can have transient and rapid influx of sodium, and then over time you have a slower efflux of potassium. And then this whole entire process is going to happen more and more rapidly as you administer a greater voltage to the cell. Right? The more you depolarize a cell, the more rapidly this is going to happen. And so here's another conclusion. So we said how sodium-potassium conductance changes over time, and the other conclusion from this is that sodium and potassium conductance are going to be voltage dependent. And so depolarization of neuronal membranes, it's going to be resulting from ion currents, and it's going to be due to the conductance of sodium, the conductance of potassium activation, and then also sodium inactivation as well. So those are all the things that affect the movement of these ions. Again, the changes of, the magnitude of movement is going to be a factor of the charge, right? So the more depolarization, the more potential that you administer to the cell, the more rapidly the either influx or efflux of potassium and sodium will be. So the more charge, the faster. And again, I'm not going to make you guys do any calculations, but it's good to know some of the figures that help to establish some of the early models in understanding the currents of sodium and potassium. So Hodgkin and Huxley were two of the researchers that helped to establish these early studies. And they were able to help establish studies to predict the actual conductance of sodium and potassium. And so this is a model that they created, so you can see the different factors that come into play with manipulating the charges. So you have the capacitance, it's basically a battery, right? This whole entire thing is basically a battery, and manipulating the charges, positive and negative, to see how that's going to affect movement of ions. So again, here is another graph depicting the Hodgkin and Huxley model. And you can see the overall change of the membrane potential and each of the ions that are responsible for the changes of movement, right? So the movement of ions again across the concentration gradient. So you can measure conductance with depolarization. And so this also helped to identify what the absolute refractory period was, right? So the Hodgkin and Huxley model, that's kind of how we were able to understand that when you stimulate a neuron, you can't just keep on stimulating it, right? You have to allow for the ions to move into their proper places and then eventually reestablish the concentration gradient so that you can re-stimulate that neuron. So you can't continually depolarize a neuron. You have to have a little lag period. And that's where you have the absolute refractory period. So if you stimulate an axon with two current pulses at variable intervals, an action potential will not fire in response to the second pulse if it occurs too short of a time, right? If it occurs too rapidly. So that is what we are referring to when we discuss the refractory period. So here are a couple other images of stimulating an axon from a squid neuron, and basically demonstrates how the refractory period works. So you have your first stimulation. The first stimulus is going to also be the one that evokes the action potential. And then if you keep on trying to stimulate that neuron, you're going to get either no response if it happens too rapidly, or you're going to have a diminished response. So recall last time we were discussing, we had absolute refractory period, and then we had the relative refractory period. The absolute refractory period, you're not going to get a second depolarization, right? You have to reestablish that concentration gradient before you can get another action potential. The relative refractory period, you could get another depolarization. It might be smaller in magnitude, and it might require a greater stimulus, but you could potentially get another action potential. And that's going to be demonstrated over here. So here is your absolute refractory period over here. It's about 4.5 milliseconds. But as you go a little bit further, if you stimulate again at 6 milliseconds, then you can actually get another action potential. But look, it's diminished. So when you're in that relative refractory period, the stimulus is going to diminish itself until you can reestablish the ion gradients and then get another stimulus. And for this case, it took about 9 milliseconds for you to go beyond that absolute refractory period. Or sorry, the relative refractory period. Moving on. And then, did you have a question? What? You answered your own question? Nice. All right, so this is sort of a feedback loop. So it's a feedback loop in the generation of action potentials. These action potentials are self-regenerating, right? So that's, depends on sodium channels opening up and at what times they open up, as well as potassium channels. So again, when you have a depolarization signal, the first thing that happens is that sodium channels open up. Then you get inward influx of sodium into the cell, allowing for actual depolarization. Then at that point, then you're going to have the opening of your potassium channels. But again, that happens slowly, right? That's why you have a slower efflux of potassium. And then at a certain point, you get hyperpolarization, or you get that kind of overshoot where it becomes too negative, but then eventually it reestablishes itself. And then it goes back down to its resting membrane potential. Now, from these types of studies, that's where we're able to figure out that when a nerve depolarizes, this is an all or nothing type of phenomenon. And it also requires a certain threshold, right? You have to reach a certain threshold to be able to get a full-blown action potential to take place. So here's another graphical depiction of what's going on with the different channels. So you have your fast positive cycle, right? Fast positive cycle. What do you mean by positive? It means now you're depolarizing the cell, so you're making the charge more positive. And again, that's going to be, sodium is going to be responsible for that. So you get those voltage-gated channels opening up, then you get a rush of sodium inside the cell, it depolarizes, and then you have the slow negative cycle. And why is it negative? Because when potassium leaves the cell, it brings the charge back down to a negative resting membrane potential. So that's going to be a slow negative cycle. So fast positive cycle, sodium. Slow negative cycle is going to be potassium. And again, this whole entire phenomenon is going to be operating on a feedback system. So it's basically one giant feedback loop, a negative feedback loop. Now let's discuss the difference between active versus passive signaling. So we discussed this briefly last time, where we had passive signaling, where it's sort of the signal, you get a little bit of a conductance, right? You get depolarization, you get conductance of ions, but it's not enough to really propagate a actual signal all along the course of the axon, right? So those are passive signals. They over time dissipate. They degrade over time. Versus active electrical signaling, that's where you get a signal that can actually go all along the duration of the axon to the axon terminal. In active electrical signaling, that's especially going to happen at the nodes of Ranvier, which are those little spaces in between each myelin sheath. And that's where you get the movement of sodium into the cell, you get depolarization, and then you get also movement of potassium outside of the cell, compared to passive movement where you have the charge basically kind of just like going along the axon until it dissipates and it goes away over time. So here are some depictions from your textbook that discusses these different types of movements. So if you stimulate the neuron at a certain point, so if you put a little probe in there, you stimulate the neuron, you're going to get movement of electrical signals bidirectionally. It's going to go in both directions. And then you have voltage-gated sodium channels opening up, and then you have movement of current, but then you're also going to be losing signal as you move down the current until at some point it basically just dissipates. But if you had voltage-gated channels opening up and, or if the signal is to a magnitude enough to allow for voltage-gated channels to continue opening up, that signal is, going to propagate further and further. And these types of movements of ions that are not involving the voltage-gated channels, those are going to be also considered passive type of electrical signals. So the passive electrical signal kind of moves down until you get one of those voltage gated channels opening up. And when you get the voltage gated channels opening up, that is when you get a more active type of signal. And so those active electrical signals are what help to allow the signal to move all the way down the axon. So not passive signals. Passive signals dissipate. Active signals are what allow for propagation of the depolarization.
Could it also be thought on as like passive is like constant, whereas active is like propagating?
That'd be one way to think about it. But in terms of passive, I wouldn't say constant. I would say, because it's not constant, it's going to disappear over time. But yeah, thinking of active as being propagation, yes, that's definitely the case. With the active signal, it helps contribute to those active signals. Passive signals will, affect the overall charge of the cell, but it's not going to be the main reason why the signal is propelled all the way down the axon. So active signals are what allow for propulsion down the axon. And then what happens when the signal moves in one direction in particular, you're going to get a wake. So think about, being on in a boat and you see like the wake as a wave that's coming off towards the back of the boat as you're moving forward, right? Something kind of similar is happening with this as well. The wake for this is going to be what basically causes those refractory periods. So if you have, the closer you are to the wake, the more you're in the territory of an absolute refractory period. And so those voltage gated channels are not going to be opening up. So this basically prevents a propagation signal to go in the opposite direction. So once you establish the direction of the signal, you're going to start developing a wake as a consequence. And from that wake, that's going to basically prevent backward movement of the signal. So how does the textbook describe it? As the action potential spreads, the membrane potential repolarizes due to potassium channels opening up and the sodium channels closing. So when sodium channels open up, that's only going to allow for forward movement of the signal, right? And as the signal moves forward, those potassium channels close. So you're not going to be able to get a backward propulsion of the signal. So going in the opposite direction, sodium channels close and also potassium channels open, right? So you're going to only get the signal moving in one single direction. So here's another chart that basically talks about what that looks like, right? So you have the refractoriness. So this is moving along the course of the axon. So this would be like point A over here, point B, and then point C, right? And so with point A, where you have the original depolarization with the probe, you're going to get that rapid depolarization with sodium influx. And then as the wake moves down the axon, over here at point A, everything closed up, right? In terms of sodium channels closed up, but the potassium channels open, right? And then it continues on as you move down the axon. So it basically prevents re-excitation, and you're not going to get backward propagation of a signal. Yes.
So it was saying that like the adjacent channels open up on the second step.
You're talking about right over here?
Yeah, so like something happens and then the adjacent channels also open.
Mm-hmm. Yeah, so when you have depolarization at point A, over here, that's the signal gets sent, it starts moving down the axon, right? Then you're going to get depolarization at point B, and that's where you have the voltage gated channels opening. That's where sodium channels open up, and that's where you get the depolarization at that location. And then as it continues on, as it propagates further down the axon, you get further and further for active type electric signals. Does that make sense?
Yeah, I'm just trying to think about like how does that happen? But I think I just need to look at this more.
Yeah, no sweat. So just follow, I guess maybe just look at one of these axons first. So depolarization, sodium channels open up, and then you establish a direction, right? It's not going to move backwards anymore. And then as the electrical depolarization continues along the axon, more of those sodium channels are going to continue to open up. But then in the wake, those sodium channels that were previously open close down, right? They close, and then it prevents sodium from coming back into the cell. Okay. So that's the wake. Everything backwards is the wake as the signal moves forward down the axon. Does that make sense?
Yeah, and this is like creating the current.
Yeah, basically, it creates the current and it creates directionality of the electrical signal. Now, what else helps in this process? Myelination, right? In terms of these, this is from a squid. There's no myelin on this squid axon. So squid axons, they're huge. They're way bigger than a human axon. But they don't have myelin, right? With the human axon, because it's a lot smaller, it would be easier for that signal to dissipate much more rapidly. And so for allowing for like long distance communication of a neuron, you're going to have myelination to be able to help propagate that signal. So with an unmyelinated fiber, there are unmyelinated cells, right? Neurons, but they're going to be more for like short distance type signaling versus long distance signaling. You're going to have myelination. So here's an unmyelinated fiber where you can see the signal as it moves. So this is actually a really good image that kind of shows the wake here. So this yellow spot right here, that's the wake, right? That's going to be the refractory period. So that's where you have right away the sodium channels close back up again, and that's when you have potassium channels opening, right? And then at the red point, that's where the sodium channels open. And then as the sodium channels continue to open, that's where you have the signal moving further along down the axon. Yeah, it's basically a domino effect. Absolutely. Myelinated axon fibers are going to work a little bit different. You have what we call saltatory conduction, right? Saltatory, the term saltatory just means to jump. So saltatory signals mean that the signals jump from nodes of Ranvier to nodes of Ranvier. And that's what allows for those active movements to go even further, right? You get the active electrical signal moving way further along the line. So here's revisiting myelin, what myelin's made of. So you recall myelin's going to be made up of a lot of fatty tissues. That's why it looks white. That's why when we discuss white matter, those are going to be like your myelinated tracts. All of your tracts along your spinal cord, like the cortical spinal tract, spinal thalamic tract, also the tracts that you find within the brain that are associated with those tracts that are myelinated, those are going to be made up of a lot of lipids. So almost 80% is going to be fat. And that comes from your dietary fat. So dietary fat is important to allow for myelination. And again, that basically protects the axon to allow for the signal to propagate, and it makes the signals way faster. As I mentioned, some of the neurons that you have in your body are unmyelinated. So not all neurons are myelinated, but the ones that are required for long distance communication are myelinated because you have to have those signals be really quick, especially motor fibers. Motor fibers need to be instantaneous. During fetal development, myelination is only going to start coming into play at around 14 weeks of development, and myelination continues to develop as the child is growing, right? It only really completes into late adolescence. And if you were to do a Babinski test, then you're going to see a positive Babinski test in a child. So I'm going to show you what a Babinski test looks like later on. But effectively, what you do is you run either a pen, or you could even use like the sharp end of your reflex hammer, just run it along the foot of the child, and then all of a sudden their toes are going to fan out, right? So that would be a positive Babinski test. You can see that normally in a child, but you shouldn't see that in an adult. If you see that in an adult, that means that there's some sort of neuron damage. So I'll show you what that looks like in a second. But again, myelination, that's going to help speed things up. It makes the signal go way faster, and it also makes the signal it protects the signal over a period, over a distance, a longer distance. So it maintains the integrity of the signal. So these are the things that factor into velocity of the electrical signal. So again, axon diameter. The squid axon diameter is really huge. If we had axons that were as big as a squid's axon, the signals in a human body would be a lot faster as well. But they're not, so that's why we kind of need myelination to be able to protect those signals and make them go faster. And then the saltatory conductions, that happens specifically at the nodes of Ranvier. And that is where you find your voltage-gated channels, your voltage-gated sodium and potassium channels. Now, here's your giant squid axon. Here's the conducting velocity of a giant squid axon, 25 meters per second. Now, different neurons are going to have different speeds of conduction. So not all neurons are built the same. They're going to have, some are going to be slower, some are going to be faster. And it depends on multiple things. It depends on myelination, right? The actual diameter of the axon. So squid, 25 meters per second. The diameter is really, really big. So in terms of micrometers, it's 500 micrometers wide. So really, really big compared to humans. And they're not going to be myelinated. So the disadvantage to that is that they're going to lose, the integrity of the signal. But because the axon is so big, the signal can be, you can maintain the integrity of the signal because the axon is really large in its diameter. Now compare that with human conduction velocity. So for example, some of the motor neurons, they're going to go really rapidly. So 80 to 120. So 80 to 120, that's really fast. That is about a football field distance within 1 second. So really, really rapid, almost instantaneous. The diameter, though, note, it's very small compared to a squid's. But they're myelinated, so because they're myelinated, you maintain the integrity of the signal over long distance. Sensory axons, again, those are also extremely fast. So you have similar speeds, 80 to 120 meters per second, size of a football field. Again, diameter is also pretty small compared to that of a squid. And again, they're myelinated. But notice, some of these neurons are not myelinated. So not all neurons are going to be myelinated type neurons. So those specific type of neurons might lose their signal more readily than if they were myelinated. So here's your saltatory action potential. So you have an action potential beginning over here at point A. And then as the signal moves down the axon, then you have your second depolarization. And remember that once that depolarizes, you do get signal going backwards. You get depolarization moving backwards, but because those channels close up, you're not going to get an actual backward depolarization, right? The conduction is not going to go in the opposite direction. It's only going to go unidirectionally. And then finally, you have point C depolarizing, allowing for sodium to come in and potassium to eventually slowly leak out as well. Because of that, we are able to get further distance, so you can flow farther away. And again, voltage-gated sodium channels are present only at the nodes of Ranvier, and then voltage-gated potassium channels are present at the nodes of some axons, but not other axons. Not every single, not all axons are going to be built the same, basically. But just note that nodes of Ranvier with myelinated axons, that's where you find those voltage-gated channels. So here's another depiction of showing the speed, the changes of speed. So, so the top axon over here, unmyelinated, this is the same one, right? So it's just showing comparison of myelination versus non-myelination. So over here, point A, you have depolarization. Then at point B, it hasn't really moved very far, right? That's because of the lack of myelination. Point C, it also hasn't moved very far. Whereas at the same time, on a myelinated axon, you get depolarization at one node of Ranvier. It moves really far to the next node. Then that depolarizes, and it moves really far to the third node, and then so on and so forth, right? So that's how myelination basically allows for signals to continue on. And again, at the nodes of Ranvier, these are going to be active. You're going to have active signals. So you got active signals right over here where you have depolarization. The passive signal is going to be this other arrow where you have the movement of basically ions to allow for depolarization signals to move down, but this is passive. So this line over here, this would be considered a passive signal. And then these arrows over here are indicating more of an active electrical signal. So you get passive signal between the nodes of Ranvier, but then the active signal is taking place at the actual nodes of Ranvier themselves. All right, so here's some of the clinical applications that we're going to talk about. So Babinski reflex, again, this is how you do a Babinski reflex. You can use a pen, you can use your reflex hammer, like the handle of it, and you just swipe it along the bottom of the individual's foot. And if it curls, if the toes curl down, that's normal for an adult. So if you don't have any issues with your neurons, then that's what you would see. But if it flares out, that means abnormal in an adult, but normal in a baby. And this should go away by around 2 years of age. And that's because that's how long it takes for those the myelination to be formed properly.
Testing the Babinski reflex in infants. The Babinski reflex can be tested in infants by firmly stroking the sole of the foot with a finger or a blunt object along the lateral side from the heel to the toes. Typically in infants, a tonic dorsiflexion of the big toe as well as a plantarflexion and spreading of the small toes occur together. This is known as the Babinski sign and is physiologically present in infants until between 12 and 24 months of age. Afterwards, the sign may indicate damage to the corticospinal tract.
So in other words, corticospinal, that'd be motor neurons. So if you have any sort of motor neuron damage, then that's going to cause a positive Babinski sign. So let's watch what that looks like here. It could be motor neuron damage.
In this video, I'm going to
tumors.
demonstrate the Babinski sign, which is used in neurological screening. Hi and welcome back to Physio Tutors. The Babinski sign has a recorded sensitivity of 51% and specificity of 99% in the detection of an upper motor neuron lesion, as reported in a study by Jaramillo et al. In year 2014. To test for the Babinski sign, run a pointed object from the heel along the lateral aspect of the foot forwards towards the great toe. In a normal human being, it will result in the flexor reflex or grasping of the toes. The Babinski sign or reflex is a pathological reflex and is characterized by extension of the big toe and abduction of the other toes, which is also called the fan sign or signe de levante. In severe cases, the Babinski sign may be accompanied by hip and knee flexion. A positive Babinski sign indicates disturbance of the pyramidal system, either from structural damage or temporary disturbance due to epilepsy or intoxication. Okay, if you want to know more about neurological assessment of the lower limb, make sure to check out our videos on the straight leg raise test and the slump test,
Okay. So again, if you have a positive Babinski sign, it could be due to motor neuron lesion, or it could also be due to tumor. So tumors, ALS, which is amyotrophic lateral sclerosis. Remember, that's involving both upper and lower motor neurons. All right, so if you have lesions to any of your motor neurons, you're going to see a positive Babinski test. And then multiple sclerosis, which we're going to talk about in a second here. So here are some other things that can cause demyelination. So whenever you have any of these different types of conditions, you can have damage to the myelin sheaths. It can be autoimmune, or it could be due to the toxins of bacterial infection. So with diphtheria, I'm sure every single one of us in this room has probably had the Tdap or the DTaP vaccine when we were kids. That's going to be diphtheria, pertussis, and tetanus, right? So it's a trifecta on that vaccine. So it addresses all those different conditions. So with diphtheria, which is a really nasty condition that especially affects like younger individuals, you get these really like horrendous pseudomembranous type patches on the throat that are extremely painful. You also get damage to Schwann cells, and Schwann cells, those are what you find within the peripheral nervous system. And then there's Guillain-Barré syndrome, and Guillain-Barré syndrome is generally going to be a result of, it could be either the viral infection itself, or it could be due to vaccination. There's many different types of antiviral vaccines that can result in Guillain-Barré syndrome. Pretty rare. It happens like in 1 out of 1 million individuals, but when it happens, not great. You start getting peripheral, what would you call it? Kind of like flaccid type paralysis. That's going to be starting kind of lower extremities, and it slowly moves its way up the body. I've even like during my times in clinical, during my clinical rotations, I only saw, it wasn't even one of my direct patients. It was someone that was being, taken care of by our team at the hospital. There's one person there that had Guillain-Barré syndrome, and that was secondary to a vaccination. So it can happen, but again, like I said, it's super, super rare. But let's watch a video on it.
This is Ned the nerd. He might look a little funny. but he has a very important job to do in your body by helping your muscles move when you want them to. But sometimes your muscles don't move when you want because of a nerve injury or disease. One disease that can do that is Guillain-Barré syndrome. We just call it GBS for short. Maybe someone you know has been diagnosed with GBS, or maybe even yourself. If so, you probably want to know more about GBS and how it involves nerves like Ned. First, more about Ned's job. Nerve cells, or neurons, send and receive messages to and from your body using electrochemical impulses. The nerve cells involved in your peripheral nervous system, which controls the ability to feel and move, have extensions called axons that can be several feet long and are covered in a fatty coating called myelin. You can think of myelin like the insulation around an electric wire. It helps to speed transmission of messages along the nerves and make sure that the messages get to the right place at the right time. But with GBS, the myelin coating around the nerves is damaged and removed, which stops the nerves from delivering their messages properly. The first signs of GBS are often a weakness or tingling in your legs. Think about it. The nerves in your foot extend all the way up to your brain. There's a lot of places for a message to get lost. As GBS progresses, numbness and weakness usually spreads up your body, and in some serious cases, it can affect your breathing and facial muscles as well. Doctors will have to run a few tests to confirm if you have GBS, including a lumbar puncture and an EMG. Plasmapheresis and IVIG are often helpful to shorten the course of GBS and limit nerve damage. The acute phase of GBS typically varies in length from 4 to 6 weeks, with over 90% of patients moving into the rehabilitative phase within 4 weeks. You might be wondering how you got GBS in the first place. The truth is, doctors aren't 100% sure what causes GBS. But we do know that 60 to 80% of cases are preceded by some sort of bacterial or viral infection like the flu or food poisoning. Because of how GBS works, it isn't hereditary or contagious, so you don't need to worry about passing it on to your friends and family. Also, GBS has a very low mortality rate, and 95% of patients recover to varying degrees from it. The chances of getting GBS again are the same as getting GBS in the first place, about 1 in 100,000. Recovery from GBS may take 6 months to 2 years or even longer, and many patients continue to have long-term recurrences of fatigue and or exhaustion, as well as pain, numbness, and muscle aches. However, there is life after GBS, and the GBS CIDP Foundation International is committed to supporting you on your journey to recovery. The foundation has information, support services, and educational community events to help you and your family adjust to your new life.
Cool. So I think I need to update this slide. This is probably from the flu shot. So 1 out of 100,000, 1 out of a million from the flu shot, but it sounds like it's a 1 out of 100,000 in general in terms of incidence. So I'd have to take a look at that. So as they were mentioning, it's going to affect predominantly some of those longer neurons. So based off of what we talked about last time we met, what would be like one of the first neurons that would maybe get affected? A very specific neuron. For those of you who were here the other day. Remember we talked about what's the largest cell in the body? What's the largest, No, for both males and females. Remember how it's affecting the legs?
Sciatic.
Yeah, the sciatic nerve. So the sciatic nerve would be like one of the first ones to get affected because it's the largest cell in the body of both males and females. So multiple sclerosis, that's going to be another one. We discussed this before in this class, but let's go into it again. Multiple sclerosis, how's it work? Very similar to Guillain-Barré syndrome. Guillain-Barré is autoimmune, same thing with multiple sclerosis, but it's going to be, different type of condition, but it's an autoimmune condition. It affects the oligodendrocytes. So if it affects the oligodendrocytes, it affects central nervous system. So Schwann cells, peripheral, right? oligodendrocyte, central nervous system. And these are some of the things that are involved here. So you have inflammation. With the inflammation of the axons, you start getting destruction of myelin. Myelin, it can also affect the axon as well, so not just the myelin. And you start seeing a diminished nerve conduction with multiple sclerosis. Again, it is autoimmune, but still information coming out about MS. But some proteins might be involved in that, like contactin 2. I'm not going to test you on that, but it's just one of the proteins that could be involved in multiple sclerosis. Could also be affected by infection. So it could be a viral infection, other organisms, other microorganisms could be involved in this. So it's very similar to GBS, very similar to Guillain-Barré syndrome, but a little bit different. Let's do some quizzes questions. Today's going to be kind of a short one. This is kind of all I have for you guys today. So I hope you guys don't feel cheated. All right, good. Okay, let's go ahead and begin. All right, so the voltage clamp method. Let's see if this is a softball question. Oh, I selected the wrong option. Yeah, so that is definitely the wrong option. And I just turned my computer off here. So controlling the membrane potential of a cell while measuring the resulting ionic currents, that's the correct answer. So the correct answer is E. So I apologize for that. I'll go ahead and fix that once my computer is back up again. So good job on that. All right, good. Looks like most of you guys got this correct. So which statement about sodium permeability during an action potential is most accurate? The correct answer is, where is it? There we go. It's responsible for the rising phase of the action potential. That's absolutely correct. Absolutely correct. And it is short lasting, right? The one that's longer lasting would be the potassium movement. So good. Excellent. Good job. Good. So voltage clamp method controls the membrane potential. The membrane potential. It's not going to control the amplitude. Well, that's not the primary reason is to use the voltage clamp. If you change the membrane potential, right, by clamping it at a certain voltage, then that's going to affect the amplitude of the action potential in different ways, right? So you're controlling specifically the membrane potential. That's what you're doing with the clamp. Does that make sense? Yeah. All right. So direct measurement of current flowing through the cell membrane. That's why you use a voltage clamp method. Let's see, measuring the current flowing through a single ion channel. You can do multiple ion channels with this, right? So it's kind of, you're not isolating a single ion channel. What does do that is going to be the patch clamp method, which is what we're going to describe next time. So with the patch clamp method, you take like a little tiny pipette with a cannula on it, and then you literally remove one single ion channel from a neuron, and then you can actually be able to understand how that one single ion channel works, right? Like what kind of voltage is required for the ion channel to open up, etc. So that isolates. It's a patch clamp method because you're patching. You're taking one tiny patch of the neuron. So that would be more in line with C. It's not going to be indirect measurement. This is direct measurement. Studying the ionic composition of the intracellular environment. Not so much. It's more so trying to figure out the current and like the direction of flow of the ions when you're setting the memory potential to a certain voltage. So let's continue on. Good. Transient inward current. So the capacitive current, that's like right when you like set the voltage, you're going to see like a little blip. That's the capacitive current, but that just happens just because of like the change in the current when you're setting the clamp. Transient inward current is going to be associated with sodium, right? So it's going to be short, brief, and the sodium is going to come within the axon itself. So that's why it's transient and it's inward. So quick, and it's going to be moving the sodium within the cell, assuming there's enough sodium concentration outside of the cell. If there's not, then it's going to be the opposite direction, right? It's going to be an outward current of sodium.
I thought of what I was trying to ask earlier. How does the adjacent one know to open up?
You're talking about
like in that second step, like why does the first one opening tell the second one to open as well?
It's because of the depolarization. So once you get the membrane, you're changing the polarity of the membrane, and then you're changing the conformation of the ion channel. So we're going to talk about this next time when we discuss ion channels. So whenever you have a voltage-gated channel, there's going to be these portions of the protein that are like positively charged, and as the positive current moves through the inside of the axon, those positively charged proteins kind of shift aside, and when they move, that's when the ion channel actually opens, and then the ions can move back in, like sodium, for example, can move into the cell. And then as that current continues throughout and propagates through the duration of the axon, then that's going to affect the positively charged proteins on the inside of like the protein channel. I described that very poorly, didn't I?
I think what you're saying is fine.
We're gonna talk about that specifically next time when we discuss the different types of ion channels, like specifically the voltage gated ion channels. So it has to do with the shape and the conformation of the ion channel. So there's like these transmembrane sections of an ion channel, and within the transmembrane section on the inside of the cell, there's going to be these like positively charged proteins that are attached directly to. It's part of these, there's like different like subunits of ion channels, and so these positively charged subunits basically shift due to the changes of electrical charge within the cell.
And then that'll tell the next one.
Yeah. So then when those change conformation, and then now you have ions flooding into the cell, those ions dissipate throughout the cell. Remember, that's the passive electrical signal. That the active electrical signal is where you have movement directly through the channel, and the passive signal moves throughout the duration of the axon until it gets in contact with another ion channel, allowing that next ion channel to open up, allowing more sodium to come in.
And because so it's going both directions, but because these ones are closed, it's forcing the only option to be the next ones to open.
Well, it's also timed too. The sodium channels open faster than the potassium channels. So the sodium channels open up really rapidly, allows influx of sodium, so that the downstream channels can open up. But then the upstream channels that already just closed, they remain closed during that absolute refractory period, right? So they're going to stay closed because that's just how it is. They're just going to stay closed. There's not enough electrical signal to allow those to open up again. Does that make any sense?
It's definitely making a lot more sense, yeah.
Yeah, and then that's what leaves behind basically the wake, right? A wake of channels that are closed, sodium channels that are closed, but then the potassium channels are opened because it's allowing the potassium to efflux out of the cell to now reestablish the resting membrane potential. Yeah? Yeah. All right, that I probably didn't describe that very well. We're going to talk about it again next week with like those charges. So yeah, we'll bring that back up again. If after next week it's still confusing, I'll try to come up with like a diagram of some sort that would probably help illustrate that point a little bit more clearly. The key event at membrane potential is 0 millivolts. Let's see if you can see this image bigger. Oh man, it's kind of hard to see the image. Dang it. No. Anyways, so if you're able to see the image over there, there's going to be a little curve that's associated with the inward current, right? And at 0 millivolts, that little inward current is at its largest amplitude. And so we're at 0 millivolts, that's where you get the early current is at its maximum. That's the highest it's going to be, right? As you increase the charge, that little inward current actually kind of goes down a little bit. And so 0 millivolts is where you have the maximum in terms of inward current. So I know those charts can be a little confusing. I'm probably not going to put one of those on the exam, but regardless.
Huxleys are just a killer family, huh?
I know, right?
I was reading about them last week.
Also, one of Darwin's contemporaries was one of the like great grandfather Huxleys.
Yeah.
Then you had Aldous Huxley, and yeah, it's
crazy.
Yeah, they're like basically British royalty.
All like super humanitarian too.
Yeah, they're wild. All right, so if you look back at those, the slides here, let's go back again. So 54 millivolts was where they established, or was it? Was it this one? No. Right here. So for sodium, that's where you have electrochemical equilibrium around 55. There's not going to be any current when you're using the voltage clamp method at around 52 millivolts. So whenever you're around like close to 55, 52, around that area, that's where you're going to see basically movement of the sodium ions are not going to be taking place, right, at that particular voltage. So you can get zero movement of sodium at positive 52, positive 55-ish, around that area. And so to be able to see what's going on with sodium specifically, so you're just looking at potassium currents and seeing how, if you remove sodium from the equation, what would happen? That's what you do. You just remove sodium entirely from the experiment. And then now you can isolate basically just what potassium does. And so that would be one of the practical ways you could do that. Another practical way you could do that too is by using a drug to block those sodium channels. That'd be another way to do it as well. And tetraethylammonium potassium channels. Okay.
Yeah.
All right, good. Yeah, that's exactly what happens, right? Sodium channels open, sodium currents increase, and then you have potassium channels opening up as well. The potassium channels allow now to reestablish the resting membrane potential. All right, good. That's quite a spread. So, which statement correctly defined or differentiates between passive and active currents in a myelinated axon? So remember, the passive currents are what would be moving from one node of Ranvier towards the other within the cell, right? But that's going to be what allows for eventually those channels to open up. And then when those channels open up, then you have the active current where you have sodium influx at the nodes of Ranvier. So active currents are only going to be taking place at the nodes of Ranvier specifically. Whereas the passive current will, move along the axon and would eventually dissipate if it wasn't for myelin sheets. Right? So active current is what allows for propagation of the signal. All right, definitely not all the above. So with multiple sclerosis, you're getting demyelination of your oligodendrocytes. And so with demyelination, you're going to see sensory neurons are going to be involved in that. So when you think about multiple sclerosis, a really good condition to think about would be trigeminal neuralgia, right? Trigeminal neuralgia patients almost always it's going to be associated with multiple sclerosis. And so do you guys remember what trigeminal neuralgia was when we discussed that earlier on the semester? So it's, yeah, you get massive pain in the face. So that is, yeah, some people commit suicide from it. It's so insanely painful. And that's sensory input from the face. Right? So when you think about MS, think about it as affecting sensory information. So somatosensory myelinated axons are going to be affected by that. Does that make sense? So it's not going to be really affecting the motor neurons. It's not going to be necessarily affecting the optic nerve, although it could affect the motor. It could affect the optic nerve, so it could cause some vision issues. So A could be an option. So I would say A and C could potentially be viable options. Seizures, you're not going to see seizures in MS. So let me reword this question. So when you get back to it later, I'll consider putting A as, either rewording it so it's more specific, or maybe consider making A as a potential option as well. But definitely C. So think about MS, think about things like trigeminal neuralgia. And how do you treat trigeminal neuralgia? One of the best ways to treat it is to go in there and just do a surgical ablation of the neuron, right? You kill the pain. You're not going to feel anything on the face, but at least you're going to kill the pain. All right, one last question before we get out of here. All right, cool. Immune response within the nervous system. So that's what's going on with MS, right? It's an autoimmune condition. So I went ahead and I actually fixed that option on there. So I'm making it blindness due to lesions of the optic nerve as well as myelin. So that'll be another correct option answer choice when you revisit that question later. And I also fixed that first question too, so you have the correct answer option there. All right, guys, any questions? Rock and roll. Well, right on. Have a great weekend, guys.
You too.
Yep, appreciate it.